Hi, everyone. Thank you very much for joining us this evening. My name is Maggie Chong, and I am the RFS PR and Communications co-chair. Just to remind you, tonight's webinar will be recorded, and if you'd like to access the video at any time, please feel free to go to the YouTube SIR-RFS channel and look under IR Education. If you have any questions at any time during this webinar, please feel free to submit your question through the chat box in the corner, and we'll answer the questions at the end of the webinar. And with that, I will turn over the webinar to our moderators for this evening.
All right, thank you, Maggie. Good evening, everybody, and thank you again for attending tonight's webinar entitled Improving IR Response Times and Management During Trauma Cases. This is presented by the Trauma Division of the SIR-RFS Vascular Disease Service Line. My name is Akhil Khetharpal. I'm currently a PGY4 radiology resident at VCU, and I'll be co-moderating tonight's webinar with Leanne Dumeni, who is a GS1 MD PhD candidate at the MD PhD program at the University of Florida. So our agenda for tonight, we'll go over a brief statement of our goals. We'll do an introduction of our panel members, and then we have 4 attendings who have agreed to volunteer their time and present topics related to our webinar tonight, which are going to be reducing trauma response times for IR by Dr. Suri, coordination of multidisciplinary interprofessional care during resuscitation by Dr. Calland, hybrid ORs and endovascular trauma care by Dr. Conrad, and rapid response in aortic injury by Dr. Engel. Ideally, we'll have some time for some audience-submitted questions at the end. If, however, the webinar is running long, we might not be able to get to that, but we'll just have to kind of see time-wise how things go. So a brief statement of our goals. The role of endovascular treatments for traumatic vascular and solid organ injuries continues to expand, and the treatment of trauma patients involves providers from multiple specialties as well as the use of multiple physical locations in the hospital. Our goal is to always find ways to improve the efficiency of care for trauma patients in this multidisciplinary system and to begin thinking about potential improvements early in training at the medical student and resident level. And the reason we wanted to have this webinar is to kind of hopefully foster that thought process and new ideas at the medical student and resident and fellow level about how to improve IR's role in the system of trauma and, understanding how the system works and really thinking about specific details that are involved in treating these patients. So hopefully this webinar will foster some ideas and some discussion on that. And now I'll turn it over to Leanne, who's going to do our attending panel member introductions.
Thanks, Akhil. So first, we will hear from Dr. Rajeev Suri. He is an interventional radiologist at the University of Texas in San Antonio, where he also serves as the program director for the radiology residency. He pursued his medical degree at Punjab University. His radiology residency was at Cedars-Sinai Medical Center, and his fellowship was in cardiovascular and abdominal interventional radiology at UCLA. His clinical interests include endovascular treatment of traumatic injury, carotid artery stent placement, chemoembolization, infrainguinal arterial interventions, radiofrequency ablations, uterine fibroid embolizations, and TIPS. Second, we will hear from Dr. James Calland, a trauma and acute care surgeon at the University of Virginia Medical Center. He is the Associate Chief Medical Officer for Acute Care and the Associate Medical Director of the Trauma Program at the University of Virginia. He went to medical school at the Mount Sinai School of Medicine. His general surgery residency was at University of Virginia. He did a traumatology and surgical critical care fellowship at the Hospital of the University of Pennsylvania. His clinical interests include surgical and trauma outcomes, injury prevention, physiologic predictors of clinical decompensation, and international surgical development and measurement of capacity. The next speaker will be Dr. Miles Conrad. He is an interventional radiologist at UCSF. There he is the co-director of the Hereditary Hemorrhagic Telangiectasia Center of Excellence. He went to Dartmouth Medical School, then to the University of Arizona for his radiology residency and his IR fellowship. His clinical interests include endovascular embolizations for treatment of trauma, uterine fibroids, liver neoplasms, treatment of DVTs, pulmonary embolus, portal hypertension, including TIPS, liver, kidney, and lung tumor ablation. And our final speaker tonight will be Dr. John Engel. He is an interventional radiologist at the University of Virginia Medical Center. There, he is the director of the Division of Vascular and Interventional Radiology. He earned his medical degree from the University of Nebraska. He did his radiology residency at Truman Medical Center and his IR fellowship at the University of Virginia. His clinical interests include traumatic aortic injury, peripheral arterial disease, aortic aneurysms, venous insufficiency, venous thromboembolic disease, dialysis access maintenance, renovascular hypertension, and tumor ablation.
All right, awesome, Leanne, thank you. And now we're going to go on to the individual topic presentations portion of our webinar. Our first presenter is going to be Dr. Suri, presenting Reducing Trauma Response Times for IR. And Dr. Suri, I'm going to share your screen now.
Okay, good evening, everybody, and hope you can hear me well, but thank you so much for inviting me for this presentation, and thanks to both Akhil and Leanne for coordinating this webinar from the Trauma Division of the Society of Interventional Radiology Resident Fellow Section of the Vascular Disease Service Line, and thanks to Maggie for coordinating the logistics in managing that. So I'm going to talk today about reducing trauma response times for interventional radiology, a multidisciplinary team approach. We are a center in South Texas in San Antonio. It's a level 1 trauma center. It's a 700-bedded hospital that covers not only the 1.3 million people in San Antonio, but close to approximately 1/6 of the state of Texas. So we have a very large catchment area for our level 1 trauma. And being a level 1 trauma center, I'm pretty sure all sites that see this level 1 trauma will see this variety of trauma cases involving splenic arterial injury to the liver injury, renal injury, renal devascularization, the whole spectrum. I know Dr. Calland will be talking about that, but the role once we see these patients coming to the ED is stabilization in the ED. And if patients cannot be stabilized, they are unstable despite resuscitation with a systolic of less than 90. They sometimes don't even go for imaging, go to a peritoneal lavage and straight to surgery. Those are patients that we sometimes do not even see in the IR or the radiology world. But most of these patients would get CT scans for evaluation, and then depending on what we see on a CT scan, be it extravasation on CT, they would definitely get transfusion, and then accordingly plan for if they are stable enough to undergo a rapid angiogram and selective embolization. The selective embolization is obviously the crux of treatment from the IR world. Now, the question always comes, what is a good time as far as when should IR be there to be able to do a procedure? Now, compared to most of the other services like trauma or vascular who are in-house, in most services, though you might have a diagnostic radiology resident in-house, you would not have an interventional radiologist in-house. So that's when the on-call radiologist is coming in for a procedure. Though there are no definite defined guidelines in the SIR world for something like that, or even in the trauma world, as to what's a good time. This is one of the guidelines that I saw in the Royal College of Radiology under the standards of practice and guidelines, guidance for trauma radiology in severely injured patients, where they say, per standard 17, IR trauma team should be in place within 60 minutes of patient admission or within 30 minutes of referral. Now that is generally, in the US world, generally a tall order, and we kind of analyze our data, what we did, and what we've done over the last few years to kind of reach closer to this. So how fast is fast in IR trauma response? Moving the concept of hilarity. Obviously, this is for people who are in the radiology world know what we're talking about. as low as reasonably achievable. This is basically for radiation, but I'm taking the next step to see what about turnaround times for trauma response. Now, prior to 2014, our trauma response time from the moment somebody would call us for an IR procedure to the time we were able to stick, that means access the right groin to be able to start the angio, was somewhere from 60 to 90 minutes. Our aim over the last 3 years has been to try to reduce this time to less than 30 minutes. So what are the challenges that we face from the IR side of things? Well, first thing is all these patients coming to the IR suite require monitoring. So you need an IR nurse. So, and that's again, the variation starts kicking in. You have IR nurses in many places in-house, but then they have other responsibilities towards CT or MR. There are very few IR nurse or nurses just dedicated to interventional radiology. In some places, the nurses could be on call, and that involves travel time, coming to the hospital, setting up and everything. Can we have support from anesthesia? Now, remember, most interventional radiology suites are outside the OR. Getting support from anesthesia can become very difficult, especially for very complex trauma patients. So, as is true for most practices, we use probably anesthesia maybe less than 10% of time for all our even inpatient, outpatient procedures. So imagine getting them after hours or on weekends for support. That'd be tough. The IR technologists, almost all places on call. So again, the issues related to travel time coming in, other responsibilities. They might be covering neuro IR. If you have neuro IR going on for stroke, do you have backup IR technologists for trauma? And then obviously interventional radiologists, where they could be related to delays in decision, and I'll discuss about that in a minute, and again, travel time. And then challenges from the ER, delays due to multi-trauma. It could be the same patient having fractures you want to stabilize. Maybe there's a brain injury, somebody's looking at that, or multiple other multi-trauma coming in at the same time, and you're trying to then assign your resources to which patient to deal with first. Delays in decision, if there are no established protocols in trauma settings, what is the best option? Should you go OR? Should you do the interventional embolization approach? Or should you wait and watch on these patients? And obviously, the same thing again comes to transport to the IR suite. That, okay, we're planning to move these patients to the IR suite. Do we have dedicated transport available? Who will monitor these patients when they're going to the IR suite? Can you spare a PA or a resident or somebody to go with them? How do you manage these patients in the IR suite? Is just left to IR? Does trauma manage that? So this is kind of the norm of what you would love to see. Patient has a bleed on CT, and you want to be able to do an angiogram and see the extravasation, and that treat accordingly. But what is involved in going from point A to point B? So I'm giving an example of a patient, a 33-year-old male, status post motor vehicle accident, motor vehicle versus pedestrian, transferred to the University Hospital with left flank bruising, pain, left leg pain, vitals 104/72 at admission, heart rate 90s, maintained O2 sats. Per protocol from trauma evaluation, patient underwent a CT chest and abdomen after initial resuscitation. The door to CT time was 12 minutes, and we've been able to get our door to CT time in less than 15 minutes consistently over the last 7 years, because we have 2 dedicated CT scanners in the ED. One of them is almost always kept, the moment we come to know that trauma is coming in, is kept apart for that, and then obviously x-rays there. So this is a case that we saw in the initial images. This was the patient, as you can see, has active extravasation from the spleen, has a perisplenic hematoma, has some air in the subcutaneous soft tissues, or see some fluid around the liver. So there's active extravasation from the spleen, as you can see out here. The patient also had a fracture of the left femur. I didn't bring those x-rays for that. So per the AAST, there's a American Association for Surgeons for Trauma. Per the splenic injury scale, this would qualify into an AAST-3, where you can see a laceration around 3 centimeters involving the trabecular vessels, where there was some active extravasation that is out there. And at least at our institution, the indications for intervention, and these were upgraded obviously by the American College of Surgeons recently, I've seen over the last few years. Indications for intervention are active extravasation or pseudoaneurysm, significant hemoperitoneum, an AST grade of 3 to 5, a declining hematocrit, and persistent tachycardia despite adequate resuscitation. So what happens at our place, or at least till around 2012, 2013? So the in-house radiologist would contact the trauma team with a CT positive result. Trauma, again, I'm not sure who is it. Is it the faculty? Is it the third-year resident, the chief resident, or a designated PA? Reviewed the studies and decided, okay, we are going to go in the OR route or wait and watch or consider doing an emergent angio. The in-house radiologists or trauma, again, with a mix, either the radiologist or the trauma surgeon could page the IR fellow on call. That was the person listed on call for interventional radiology. The IR fellow would at home then review the images and then call the ED physician confirming that this is what they really wanted. Was the patient stable, unstable in the time that they'd got the page, had the patient's systolic dropped. Then they would contact the IR faculty. The IR faculty, after approval, would say, okay, let's proceed with the angiogram. At that time, the interventional radiology technologist, the RN who was from home, the IR faculty, and the fellow would be paged. So you can see this overall time for this whole process could be close to 30 to 45 minutes, kind of from the time we said a CT is positive to the time a page gets sent out to the IR team. Okay, so coming back to that portion, so the team has been paged. The RN, tech, and IR, that is a faculty or fellow, reach the IR suite. Now, per protocol in the hospital, you cannot move a patient to another area until you have a nurse present. And because the nurse sometimes was uncomfortable managing these patients who were coming straight from the trauma suite, they wanted at least a physician present before they could call for the patient. So that time from, most people don't live within a 10-minute radius, so it would take us 30 to 45 minutes to come in before the patient could even be called. Now, when you call the patient, well, in the meantime, the ED has its own challenges. The same patient, remember, had subcutaneous emphysema, also had a pneumothorax, they wanted to put a chest tube. Ortho was called in to fix the fracture. Patient needed some IV fluids, blood, transport issues that are there. Patient ultimately transferred to the IR suite. This process could be 0 minutes, but could be up to 30 to 45 minutes depending on ER issues. Tech preps the table, RN sets up monitoring, patient prepped. This could be additional 15 to 30 minutes depending on how stable the patient is and everything. And then IR is ready to access the groin. So as in this patient, as you can see, we see active extravasation on the aortogram. We go selective, we see active bleed. And you can go out there and you can either, if it's a single bleed, we do a peripheral embolization. You can do multiple bleeds. You can use gel foam at our institution. If it's 3 or less focal bleeds, we coil. If there are more, we'd use gel foam. So kind of summarizing that time frame that we saw from the initial contact from radiology to the time the IR team was paid, that was around 30 minutes. Patient called to the IR. Now, these are delays related to IR issues, was another 30 to 45 minutes. Patient reaching the IR suite. Now, from the time IR is all set, ready to go, till the time the AR patient reaches out there, could be 0 to 30, sometimes up to 45 minutes. And we start the case after setting up and everything. So this whole time could be close to 100 to 165 minutes. So, I said that we were aiming, so most of our patients would be in the 60 to 90 range, but we had patients going up to close to 2.5 to 3 hours from the time somebody got paged. So our turnaround times for IR in an average range in this time frame up to 2013. Obviously, what are the challenges involved with that? Critical time is lost. Patients can get unstable with time. Maybe when they call the IR people, the systolic was good. Now the patient is unstable. That would mean the treatment plan could change to the OR versus IR as time increases. Difficulty in arranging for anesthesia in the IR suite, as we talked about that, for complex cases. And the IR suite was not set up for emergent surgical interventions. If the patient started crashing the IR suite, how do you manage these patients? I know Dr. Conrad will be talking about hybrid ORs, but I'll talk about that in a minute. So for us, then the quick question started coming up, was this something that was sustainable? As turnaround time is critical, we need to intervene in these patients. What should we do? Should it be IR who should step up to be there early? Or do we consider alternative options where vascular surgery or trauma could be there because they are in-house? Obviously, that leads up to issues regarding the turf issues that we always talk about. Can trauma surgery or vascular surgery get the skill sets needed to do that? Well, it's easy. You can go to some workshops and you can start doing that. But we wanted to be an active part of the patient care team, and we felt that we needed to kind of use, this is the guidelines from both RCR and also one of the articles from the radiology world, where they said to be a successful IR practice for trauma, you have to have skilled IR available on urgent notice, availability of high-quality DS equipment, which we have, where we have skilled nursing for monitoring of these patients and ability to be there within 30 to 60 minutes. So we took it on upon ourselves to see what we can do to reach that effort. So as I was saying, Dr. Conrad will be talking about hybrid ORs, but when we got that hybrid OR in 2013 at our institution, we'd already started the process, but that really helped morph everything into one way. So I'm going to use like a workflow intervention that we did. So using the Ischemia diagram, we kind of went through different processes and see where we could make the changes. So let's say step one, or point one, the radiologist reads the CT and contacts trauma for a CT positive result. So what are things that can help with that? Well, we already said that for our door to CT time, we already were good. We have more than one CT scanner. We've set up multiple viewing stations, not even in the CT area, but all around the trauma bay for surgeons to quickly look at the images, so they didn't need to come every time they had a question to the IR reading room. They could obviously always come, but that was an option that was there. We created a dedicated trauma contact, what we call the pit boss. That could be a third year, generally a chief resident, mostly into the trauma service, but sometimes could be a faculty. So there was one number that you would call. You're not calling around multiple places. Now we do have 24/7 in-house radiologists. Most of the time used to be, till around 4 years back, used to be a resident from radiology, but as of around 3 years back, a hospital also requires you to have a faculty available. Now you don't need a faculty to be able to run this program, but this is more our hospital requirement. Trauma would review the studies and plan for IR versus OR versus wait time. So what are the factors involved with that? As said, that we set up detailed protocols from the trauma service in combination with IR as to what would be a consistent pathway for deciding OR versus IR. And obviously, it's still differing to the surgeon because they are directly managing these patients, whereas IR is probably seeing these patients from afar sometimes when we are at home. Obviously, as I already talked about, ease of review of these images, either with this with the viewing stations being there and or being close to the trauma bay. You can go and talk to the radiologist if you had any questions. Now came the part where's the IR. So we kind of moved to a system where we did multiple pages. We kind of contacted the IR and the OR team once we decided that procedure needed to be indicated. So once the ER recommended, because we had now established protocols, the ER recommends call to IR depending on the issues once their issues are resolved. So if a patient came in with trauma and required a chest tube placement and or required like orthofixation before they were ready for IR, they would start that process simultaneously also. And for consistency purposes, they would then say, okay, have the ED radiologist activate what's called code angio. Now, we were able to, from the time a person, and I'll talk about what a code angio is, so basically from a time a radiologist says CT positive for extravasation to the time the whole team gets called, we reduce that time to 10 minutes from 30 to 45 minutes. So what is a code angio system? It's a system that we use this site called everbridge.com. It's assimilated within our EMR system. It pages both the mobile and the pages alternative and keeps going back and forth every 2 minutes till you say yes, either through your phone through a text message or in a response system to the mobile phone. Otherwise, they'll keep calling you because they want to make sure that you got the message. Simultaneous messages were sent to the IR team, that is the tech, IR faculty, IR fellow or resident on call. We would not question why we were getting called because these were protocols that we already agreed to. You start on call. The moment you get a page, you leave from home. You aim to be in the OR in less than 30 minutes. You can always call the ER radiologist or the pit boss. The pit boss, that is the person in charge in the ED for coordinating care out there, for any questions that are there. They would also, at the same time, the page would go out through the same simultaneous system. The OR board coordinator, our hybrid suites are in the OR. We have 2 of them. So they would start rallying resources for the dedicated hybrid OR, having the OR surge techs and the RNs be there. OR anesthesia was contacted at the same time, and OR/ED transport was contacted at the same time. So again, going back to the fact that, okay, the patient is now directly reaching the hybrid OR. So what are the steps involved with that? Well, we have, as said, 2 hybrid ORs. The OR anesthesia, the the med-surg tech, the RN ready for the patient. Our OR suites are just one floor above the trauma bay, so you just move on to the elevator and you go straight into OR 14. That's a dedicated hybrid OR suite, so the time lost in transport is gone. So between the time the patient reads the hybrid OR suite to the time the patient is ready for us, patient getting an IV or intraarterial access by the in-house anesthesia, patient is simultaneously being prepped by the OR technologist who switches on the hybrid machine. It was already switched on the moment the page went out to the OR coordinator. The table and devices set up by the OR technologist. They know what catheters, wires, whatever we would need on every case, they'll set it up exactly. In the meantime, the IR and the IR technologists are also driving in. So all this is happening simultaneously. So we are there within 30 minutes. So the whole time that was lost of around 75 minutes, we were able to reduce it down to 30 minutes in that time frame and get access thereafter. So from the time a page goes out to the time we get access, we've been able to reduce it down to 30 minutes. We wanted to make sure that we were achieving what we wanted to achieve, and we were consistently making sure that we are addressing any problems. So we regularly meet together to assess outcomes. After every procedure, we have a huddle to assess what did we do correct, what else could we have done to make it better. We have a quarterly review of outcomes. You know, did we overcall, did we undercall for IR? What if any of the patients, while we were doing an angiogram, suddenly became unstable? What could have been done to make it better? And then we did what's called a Pareto analysis, and I'll talk about that in a minute too. So from our time from 2013, when our turnaround times were pretty high in the 2 hour plus, around the 1.5 to 2 hour range, we were able to kind of decrease our times. As you can see, the orange line is from 2015. So in the early part of 2015, you saw many of these things were outside kind of the margin of what we wanted to achieve. But in the latter part of 2015 and now 2016, we've been able to achieve times of around 30 to 50 minutes. Now some of these times, and that's what I was talking about, that every time we go above the 30-minute range, we do what's called a Pareto analysis, identify factors in each of those cases. What could we have done differently? Sometimes these are related to delays from patients coming up from the ER because suddenly the patient needs now a Foley catheter or fracture stabilization or something. So those are factors that we try to make sure that we address that. So this is our experience on what we have done to decrease turnaround times to 30 minutes or as low as achievable by doing a multidisciplinary team buy-in for this code angio concept. And we decided that we would not let anecdotal concepts define what we were planning to do. This was based on a very lean analysis of our workflow through the Ishikawa diagrams, focus on interventions to improve outcomes, and then for the outcomes we did the huddles, the Pareto analysis, which is basically the 80-20 rule where you look, 20% of the problems could be, 20% of issues could be the cause of 80% of your problems, so you try to look at those outliers and see what you can do. And that's that from me. Thank you very much.
Great, thank you, Dr. Suri. That was awesome. I'm going to change presenter screen back to myself here. Okay, and our next presenter is going to be Dr. Calland, who's going to be presenting coordination of multidisciplinary interprofessional care during resuscitation.
Perfect. Can you hear me, Akil?
I can. And then I have your slides up here, Dr. Calland.
Fantastic. So I want to thank your society, members and guests. It's just a tremendous opportunity and an honor to be asked to give this talk to all of you this evening. Appreciate you taking time out of your Sunday evening to listen in. I thought that Dr. Suri gave just a masterful talk about the incredible orchestration that's required to get a sick trauma patient into the operating room from the field and the incredible challenges that can occur in that 1 to 3 hour period after the injury between when the coils go in to stop the bleeding. I work in a similar kind of center that serves a catchment area of about 20,000 square miles. We see about 1,500 severely injured patients per year, and I'm here to talk about a slightly different topic rather than the mechanism of getting a patient into the IR suite in a timely fashion. I want to try to trying to highlight the issues related to getting them in there in a safe fashion and getting their procedure carried out with all the critical care concerns thought about and accommodated in a timely and safe fashion. Next slide. I don't have any disclosures. Next slide. So I think that any good talk begins with a clinical case. This is a recent case seen at my institution where the trauma service collaborated with the interventional radiologist for care of a sick trauma patient. This is a 66-year-old guy with a history of coronary artery disease who was recently started on Coumadin for an episode of atrial flutter that was converted in the cardiology suite. He was unfortunately about 2 weeks later in an MVC, T-boned on the driver's side, presented to an outside hospital, initially a little bit actually hypotensive. If you look at his age, it turns out that patients older than 65, a blood pressure of less than 110 is equivalent to a blood pressure less than 90 in patients who are younger. And I know that this sort of gets a lot of people's attention in young patients when they start to drop their blood pressure below 90, blood pressure of 82, 83, people get excited, start moving faster. It can be a real challenge to recognize that we have to have a similar sort of level of concern for our patients older than 65 that systolic blood pressure is less than 110. That's where the inflection point begins for mortality. So anyway, he was initially seen at this outside hospital, was pan-imaged over there, and was appreciated to have multiple injuries, including bilateral pubic, superior and inferior pubic rami fractures, a right adrenal hemorrhage, and a T-spine fracture. He was reported to, for the most part, be normotensive at the outside hospital, but did have a drop in blood pressure following narcotics, including 8 milligrams of morphine and 25 milligrams of fentanyl. And at that time was appreciated to perhaps have episode of some evolving hematoma in the pelvis. Next slide. So by the time he arrived at our organization, about an hour after his injury, he was continuing to have periods of hypotension. He received care under our highest level of trauma alerts, which includes an attending trauma surgeon within 15 minutes of the patient's arrival or the notification. And this patient had actually a transfusion requirement, went back to the CT scanner to get another set of images. I guess there was some question as to whether or not there were adequate quality images from the outside hospital. And again, we're seeing a blood pressure here that wouldn't necessarily worry us for an average younger patient, 97/64, at a heart rate of 54. No one present will be surprised to hear that he was taking beta blockers. And a venous blood gas, which is sort of our standard for our highest level of alerts. All patients in this setting get a rapid venous gas, and if we can't actually obtain that from a peripheral stick, we are very quick to go to a femoral stick to get either a venous or arterial gas, whichever one comes first. And as you look at these numbers, 7.27, a PCO2 of 50.5, a serum bicarbonate of 19, base deficit of -4, that not necessarily tremendously worrisome, but as I look at that gas, I've been thinking to myself that we only have a few points to go from 7.27 to less than 7.2, at which point this patient will begin to become unresponsive to his own endogenous serum catecholamines and may begin to have problems with hypotension. Now, I have to tell you that I look at the lactic acid below that of 2.1 and a hemoglobin and hematocrit of 13 and 38. It's a little bit hard to put this picture together. I can't, especially given the knowledge that he's gotten 1.5 liters of crystalloid at this point, I can't exactly explain why he's so acidemic, given a relatively normal serum lactate and without an impressive drop in his hemoglobin. Next slide. So indeed, he had a blush appreciated on that CAT scan. That's not a large hematoma, but some blush from the obturator artery down by the right pubic rami. And appropriately, he was referred to our radiology colleagues and accepted, and I think that he made it onto the table within about 90 minutes or something like that from his time of injury, including 2 hospitals, 2 separate trauma evaluations, et cetera. And here's where I think some of the problems begin in this case. He's rating this pain about 8 to 9 and over 10, and is having a hard time laying still. And I think that the most common response that we would have at probably most of the hospitals we're affiliated with is that our probably critical care nurses, hopefully, who would be present, or even a board-certified surgical intensivist who was present would start thinking about, do I need to give some sedation and some analgesia in order to help this patient lay still for the 45 minutes to an hour it's going to take to get his IR procedure completed. And indeed, sedation is initiated. He's at this point gotten probably about 150 of fentanyl or something like that, and 1 milligram of Versed is given in order to make him more comfortable. Next slide. This is what his images look like. You can get a hint. This is not on a bone window, but you can get a hint of the rami fractures on the left, small blush on the right, and this was the image that drove us to the IR suite to treat this blush seen on CT. Next slide. So after this 1 milligram of Madaz that you heard me say that this patient received, this was followed a short time later by bradycardia that seemed to come out of nowhere by all reports of everybody present. Patient got CPR within seconds and received some atropine with return of spontaneous circulation. A short time later, he again lost pulses, and a few moments later and had another round of CPR accompanied by atropine and epinephrine administration, again with return of spontaneous circulation. The gas that you see at the bottom of this slide is the one that followed this second round of CPR, and again, by all reports, he had very effective CPR that occurred within moments of appreciating that he was underperfused. And you can see here that his pH is 693, PCO2 of 62, PO2 of 86, adequate oxygenation, but a base deficit of -16. And what I know in our aging patients is that once you get to a base deficit of greater than -6, those patients have at least a 25% in-hospital mortality on a mature trauma service. And just so that everybody has the same situation awareness that I have as a surgical intensivist, what this gas tells me is that this patient, because he reportedly got effective CPR, this tells me that this patient was profoundly acidemic before he probably went to the IR suite from the CAT scanner. And in all likelihood, and again, this is speculation, we don't exactly know why, but my experience and intuition tells me that what's got us in trouble on this patient was that we gave a patient with profound acidemia sedatives and narcotics. And this combination, even in minuscule quantities, can take a patient who is hanging on to homeostasis with their fingernails, push them off the edge into circulatory collapse. And in my estimation, that's what happened in this case. Next slide. So he indeed stabilized out with additional transfusion and got intubated, obviously, after resuscitation, but unfortunately remained with a poor neurologic prognosis and a CT scan consistent with an anoxic brain injury. Next slide. And obviously, once you have a CT scan that's showing loss of effective gray-white differentiation and swelling, et cetera, this is, even with the best surgical intensive care and trauma care afterwards, this is not an optimal outcome. So I think that these are all lead-ins to the messages that I want to give here, and I basically am going to finish up. And unfortunately, I think that the most important thing that I have to say tonight is that line that you see at the bottom of this slide. I think that the planning for the care of a critically injured patient really is all about the team communication that goes on and the dedicated time we put into planning for what might go wrong in the high-risk things that we undertake in their care. And just to to sort of round out the idea for how we have to think about trauma patients, we all sort of know about the lethal triad: hypothermia, acidosis, and coagulopathy. And I don't think that any of us are surprised when a patient is 1 to 3 hours out from their injury and has still not yet achieved hemorrhage control, that if anything, these are going to be the rule, rather than the exception, unless we've been just incredibly diligent with keeping up with their transfusion requirements. And this is the heart of the matter, I think, for anybody who's casually watching this case, keeping up with their blood gases as well. So if we have a patient who has unexplained acidosis in the trauma bay, that is only going to get worse in the subsequent hours following their initial care. And we have to monitor that carefully and have a very low threshold to get the surgical intensivist back to the bedside or a senior surgical resident. And in my shop, what I'll tell you is that a patient who is having hypotension due to hemorrhage, that we believe that all these patients should probably have their airway controlled and be mechanically ventilated. And one of the advantages to this, of course, is that once we do that, that almost certainly mandates sort of a regular analysis of their blood gases, and in this case probably would have obviated the circulatory collapse that occurred with sedation. Now, one could ask the question, wasn't he going to potentially have circulatory collapse when he was had induction? I can't say that that wouldn't have happened, but we would have had many more personnel present at that moment, including an anesthesiologist and the trauma surgeon, to have dealt with this in a more planned fashion. So let's go to that bottom line there on this screen, this thing about the timeout. I just want to invite anybody present who is sort of thinking about their role as a physician in the care of the severely injured. And think about, many of us were athletes in our former lives prior to medical school or in college or high school, and we have to start thinking about the timeout not just as this hurdle that we have to get through in order to get to the thing we really want to do or need to do, but it's a critical opportunity to talk about the deadly opponent that we're going to face in the next hour and how we have to come together as a team and what we have to sort of acknowledge and anticipate could happen and could go wrong prior to it occurring. And I think that speaking to those in the room who are senior fellows or attending, really it must be stated that the rest of the people in the room are highly dependent upon the situation awareness of the senior surgeon, senior radiologist, senior anesthesiologist, to tell the rest of the team what could happen next and what could go wrong. And so I just want to encourage everybody present to capture this moment, use it well, and tell the other people what help you need from them in order to avoid having the patient have an adverse event in the operating room. And just the last thing I'll say is that the evidence for this I don't think that the analogy between surgery and aviation is totally solid. They're, in medicine and aviation, for us, the plane is already on fire when we get into it. But I do think it's worth noting that in a simulator, you can predict whether or not the pilot is going to lose the plane in a simulated sort of high-altitude adverse event on the basis of how many words are spoken before the plane ever takes off. How many times the captain uses the first-person plural pronoun we, how many times they use action verbs. And the message that I'm giving here is that there is a substantial leadership effect that occurs in high-risk environments, and we can actually prevent adverse events by encouraging communication before the intervention ever occurs. Again, I want to thank everybody for their time and attention. I look forward to hearing the rest of the other speakers.
All right, thank you, Dr. Calland. That was a great presentation. Our next presenter is going to be Dr. Miles Conrad, who's going to be talking about hybrid ORs and endovascular trauma care. And Dr. Conrad, I'm going to change the presenter to your screen at this time.
Okay. All right. Can you guys see me?
Again.
Okay.
So I'm going to talk about hybrid ORs and endovascular trauma care, and weave in a little bit about rubella and how that kind of changes things. It's an exciting time. It's also, you know, hybrid ORs are being built more and more in the United States. They're being integrated in with trauma services, and I think we just need to take a step back and kind of look at what's going on and what are the implications and the advantages and the pitfalls of this approach. But it is an exciting time to be an interventional radiologist. I work at San Francisco General Hospital, which was renamed Zuckerberg San Francisco General after a large gift, which we're very grateful for. And that money allowed us to buy a lot of nice equipment, which I'll show you in a minute. So first of all, I want everyone to understand, so as long as we're on the same page with what a hybrid OR means. Most people think it means a hybrid angio suite with an open OR compatibility. It's in the operating room, meaning that it's around the red line, so everybody that comes there has to be in scrubs. It can also mean a hybrid CT or angio suite. Here we have one of these in our new hospital, so it's a CT scanner on a track that comes in, and we'll talk a little bit about how that can play into the role in trauma as well, since you don't have to go to a CT scanner. You can actually do it in the room. So I think, you know, whenever there's an angio suite with OR compatibility, then you can imagine you're in a difficult situation at times where you have multiple services coming together, people doing different things. Sometimes the things we do overlap, and it can increase competition in the room. And so we just need to make sure we're all being professional and we have agreed to roles before commencing. So, so I'm gonna move this here. So anyway, so what is our future in modern trauma care? So first of all, I think hybrid ORs offer the potential for expedited endovascular care. There's no question about that. If you have a patient with a solid organ injury, for example, and they come into a hybrid OR, then you can do an endovascular procedure, or they can pack the pelvis and you can mix and match. And you don't have to transport. And transport's one of the biggest issues with delays in care. There's the potential for improved communication between our surgical colleagues and our IR staff. And it poses certain challenges and advantages because of the integration of the location, integration of technology, and those services that are all now working together for the first time in the same room. And before we understand that relationship, we need to understand a little bit about the intrinsic and extrinsic factors that motivate our other colleagues and what things that they want to think about when they're doing the procedures or their surgery. I think this potential collaboration can lead to a conflict, and so we have to remind ourselves that we are very good at what we do. We can do what we do very fast, and we have to provide very excellent service to be someone that will be referred to critically injured patients. Okay, so there is potential changes that can occur due to the hybrid OR shift, and one is that you could shift towards non-operative management. For example, more unstable patients may come for angiography because you have this surgical bailout. So the threshold for going to angiography may be lower because they're there with you, and if someone starts crashing because you can't get into a celiac to do a splenic embolization, then they could just open the abdomen and take out the spleen. Interwoven in this whole thing is rubella, resuscitative endovascular balloon occlusion of the aorta. This is being taught more and more. It's getting a lot of hype, and this could become a gateway for more endovascular procedures for our other surgical colleagues. So they may see this as an on-ramp, the common femoral artery as being an on-ramp to, go in, inflate the balloon, and then the clock starts ticking because you wonder where the interventional radiologist is. Now I have a balloon in the aorta, and I worry about ischemia time. So we have to think about how that will change the clock. A little bit about REBOA is one thing that is becoming apparent is that our emergency room colleagues are very well trained now with ultrasound, and you can confirm position, at least in thinner patients, of where the aortic occlusion balloon really lies. You can position it potentially below the renals or the SMA, and you can get kind of fancy. And you could even imagine a situation where ultrasound starts getting integrated in with REBOA onto the catheters, and there's a lot of potential for great innovation there. But this puts more focus on time and getting IR in the middle of the night. And now, again, we're in a hybrid OR, so we no longer have to worry about transportation. And timing can be documented, and it frequently is because of accreditation every several years in trauma centers, and they want to know how long it takes interventional radiologists to get in, and what's the time from the moment they get into the ED to the time of needle puncture, just like in stroke. So, for example, at our institution, this is the standard, pretty well published algorithm for treatment of pelvic fractures. And angiography is even applicable in the hypotensive patient without any CT scan. It's really rare for that to happen now, and one of the main reasons is that patients are going for extraperitoneal pelvic packing. So you can imagine a situation where in a hybrid OR, particularly if you do have a CT scanner in that OR, some people do, some people don't, it's kind of rare, but you can imagine that you may not go back towards extraperitoneal pelvic packing because you're in the operating room and you could just put an occlusion balloon in, and that may obviate the need for that. Here it is with a bunch of lap pads, placed in this midline incision, and I'd be interested to hear if Dr. Calland does that too. It's becoming more popular at a lot of centers. So I think of REBOA as a clock accelerator. Once the balloon goes up, now there's even more demand on where IR is. They need to be there because of the issue with ischemia, and even more pressure is being put on it because, at least in the UK, where doctors are in helicopters and in ambulances, there was the first reported case of REBOA being performed in the field. So you can imagine if REBOA starts getting put out earlier and earlier, even in the ER, then the ischemia time is going to be longer, and so there's even more demand on time. Not to mention the fact that REBOA is becoming easier to deploy. This is a prior medical device, FDA approved. You no longer have the 14 French coda balloons. You can start doing these with smaller balloons that are very compliant, very safe. They have a pigtail, and they'll go through a 7 French sheath. Okay, so we've talked about some of the technologies, REBOA, and let's talk a little bit about integration in the hybrid OR. First of all, there's several things to contend with, one being the physical location. So you are in this is our new hospital. We've been open since the spring. And we have IR completely within the operating room. So this is the red line that defines whether, sterility. And so you cannot come to IR and no longer in regular clothes. And you don't have to there's no longer transportation issues. You can easily transport somebody, even with just a bunch of doctors. You don't need to transport people to do that. So this affects us. We call the hybrid OR the gilded cage. Some of our pulmonologists have labeled that because now they have to put in this bunny suit. Put on this bunny suit, and a big team of people have to go put on this bunny suit and then come visit us. So we no longer get these great interactions where, you know, our non-surgical providers have great difficulty getting to us. This is one of the big limitations of a hybrid OR. So ideally, you'd have a situation where you have a room that's built, you know, you have a, you know, on the edge of the OR, and people can come and visit with you, but we didn't build it that way. We built it so we're tucked way back in the OR, and people have to go through these steps to visit us. So what this means is, in response to the hybrid OR, is that you need to now compete on the same level that the surgeons do, which is you have to have a greater floor presence. What that means, in most places, you don't have a surge, you don't have a ton of residents walking around. You know, usually there's just one IR resident on a rotation, so we have to have an army of NPs going out and doing consulting work on the floor while we do the procedures and attend clinic. The exciting part about the hybrid OR is that you have an integration of all this technology together. This is an example of the conventional hybrid OR where you have all these doctors from different services potentially working together. But, you know, you can have the angio CT thrown in, and we have a room with angio MRs, you know, where you have a docking system between the two rooms, and even integration of ultrasound. For example, the wireless ultrasound, you know, this can get mounted up here on the flat panel display, and then you can have a transducer, which, by the way, we got this system, and then we promptly threw out all the transducers within about 2 weeks. So we never got a chance to really use it. It's kind of a problem from that standpoint. And then you have integration of the services. And this is where I think some of the bigger challenges come in. You know, you do a case, you're with a surgeon, there's an IR doctor there, there's a surgeon there. The surgeon is done with their job, and now they're thinking, well, can I help you with that wire? Since you're, you know, I just explored the chest, I put a large bore tube in. Now I'm here in the room and you're here, so can I help you with that wire? Can I help you deploy that filter, for example? And the interventional radiologist is thinking, well, I have a very particular set of skills, and those skills are very particular. I mean, you're basically, the surgeon can do all this other stuff related to resuscitation of the patient, and it's a little awkward. I mean, IR is just sitting there kind of doing their own little thing. And but this is the limitation of IR in some ways, is that, you know, we're not totally involved in the rest of the care, whereas the surgeon really is, and that's one of the strengths of what they can do. So I think you need to agree to boundaries before you commence on these projects, so that, you know, you have a resident with you. That resident then is the person that assists you with the procedure, not the surgeon. That's not our job, but, you know, we appreciate our relationship, and I think everybody would appreciate if they have kind of boundaries. Trauma surgery has a lot of internal and external forces at play. From my perspective, this is just my perspective, one of the things I've run into is, you know, the surgeons say, look, listen, no patient dies of blood loss, at least in the trauma setting, outside of the OR, and I can totally understand that. They, you know, when things go down and patients do have complications or potential mortality, you know, that surgeon then has to go to a conference and talk about what happened, and that surgeon's colleagues may be blunt about the fact that, you know, the patient should have undergone an operation sooner. So, and then of course there's external forces on the trauma surgery service. For example, response times. And some surgeons are starting to see endovascular therapy as something that they should do. And there's a lot of forces driving that. One is to the fact that you can push your field into a different direction. There's a lot of rewards for young professors that go off and, you know, become quote unquote endovascular pioneers in endovascular therapy. And you have vascular surgeons with a great skill set of endovascular technique, and their residents have gone through a fair amount of vascular training as well, and they can handle wires. They know what an amplatz is, for example. There's also possibly in the future going to be a surge of endovascular trauma fellowships. I can see that happening. Right now there's small courses. And there's a bias about radiology in general and trauma surgery. This is a famous trauma surgeon giving a talk on YouTube I watched a little while ago. And, you know, people have a bias against IR because death begins in X-ray is something you hear from time to time. And this is mitigated by a hybrid room because X-ray is in the OR. So you can see that working to our advantage. But at the same time, the interventional radiologist, this is that same lecture I was telling you about by this famous trauma surgeon. The interventional radiologist is not really in-house. Now, if you were to train a endovascular trauma surgeon, well, that you may have one person that's trained in that, and that person can't live in the hospital 24/7 either. So either way, you know, you still sometimes have to deal with people that come in from home, but this affects me. I mean, when I'm called in the middle of the night, I think sometimes about, you know, this slide and the difficulties that the trauma surgeon is going through, and I realize that, you know, I need to trust my residents. If my residents tell me that there's active extrav, for example, on a CT, I don't take the time to pull up the images on my computer from bed. I just drive to the hospital and show my face in the OR and tell them I'm here and we're ready. I think endovascular procedures in general are a low-hanging fruit for trauma. There's been a surge of publications related to the fact that trauma surgeons and vascular surgeons are interested in either taking over the whole field or just, you know, getting involved. Here's a course. Actually, this is a publication out of Japan where, you know, the conclusion is a standard training program should be established for acute care specialists or trauma surgeons to make these techniques a standard part of their regimen because they're saying they can do them just as well. And there was an article published, you know, about catheter-based treatment of vascular injury can be effectively performed by acute care surgeons trained in endovascular techniques. And these are the endovascular procedures that this department performed. You can see that they did bronchial artery embolization and even, you know, splenic embolization and things like that. So, you know, this goes back to what I'm saying is rubella can be a on-ramp onto the onto endovascular procedures. There's also a 2-day course being taught, and it pains me to think that the entire field of IR, of endovascular therapy, for example, can be taught in a 2-day course. It's painful to think that someone would think that that is feasible, but that is the truth. And you know, this is a course that trains trauma surgeons on angiography, coil embolization, and rubella, and what have you. So you just need. I'm not trying to freak people out, and I'm not trying to be controversial, but I'm saying we at least need to recognize that there are all these other factors that are motivating people. So how to survive? I think that we need to recognize that our responsiveness is the key to survival. We need to be 24/7 available. I continually tell our trauma surgeons, or periodically tell them, that one of the main focuses in my life is the endovascular care of trauma patients. I care nothing more about it in my work life. And, you know, I don't know, is this a move for 24/7 IR? Should this be something we should at least consider? I think that remains open to debate. We're certainly not ready for that now. Service excellence is obviously critical, and it can only take you so far, but I think it's very important to continue to publish and lecture on these things. And one thought I had about the hybrid CT suite is that, you know, if you have a CT scanner, our home turf is the CT scanner in this nice room, this new IR room that's in the OR. And if someone has undergone an operation but they're still unstable, you can then bring them down, you can bring them across the hall to your room, do a CT scan, and then find out really what the heck is going on and proceed from there with endovascular management. So the CT scanner in the IR suite, which is in the OR, can be used to draw patients back. We need to be innovative, and you just have to get involved in understanding what the political avenues are when necessary to address these concerns. Thanks a lot.
All right, thank you, Dr. Conrad, for that excellent presentation. Our final presentation of the evening is going to be by Dr. Engel, who will be talking about rapid response in aortic injury. And Dr. Engel, I have your slides incorporated here.
Awesome. Akil and Leanne, thank you so much. What a great concept, great session, and thanks to the SIR for putting this thing technically on. So we'll talk a little bit about rapid response in aortic transection. As the other speakers have found the value of starting with an example, Forrest may very well remember this patient. 51-year-old woman had a head-on collision with a garbage truck at what seemed to be a relatively low speed, as reported at 25 miles an hour. But her blood pressure at the scene was relatively low with systolics in the 80s. She had diminished breath sounds on the right side, which led to what we call here UVA and alpha alert. The EMS was amazing. They were on the scene at 13:53, had a tough extraction, and yet had her rolling at 14:12. Upon arrival, she was intubated, paralyzed, started on ketamine, 3 units of blood pressure increased. She had a femoral line placed, femoral art line placed, a right chest tube placed, diagnostic tap, and then was taken to CT scan in less than an hour. And just to recap what several other speakers have all said is the trauma service here at UVA, like at a lot of places, is just become protocol driven and more efficient by leaps and bounds. And when you think about a patient in an hour and a half having all of this accomplished and is heading to CT scan, in other words, they're putting their trust in radiology after an hour and a half of amazing resuscitation and stabilization and access in something else. So patient also had, although a normal chest x-ray, a liver lac, pelvic fractures. And I think the other important point with these thoracic aortic injuries, of course, is all of these patients have multi-organ injury. It is always complex, and so triaging what to do in what order is really probably the most challenging part of these patients. Next slide, please. So a series of slices here. You can see some defect in the intima there, the lesser curve of the arch there next. Start to see some contained rupture or extravasation there going down to the next. And that's a frank pseudoaneurysm there. Next slide. And finally get below it there and see some relatively normal aorta. And next slide. And one more, we see a reconstruction here. And you can see contained rupture there, pseudoaneurysm, and also an intimal flap. Next slide. Aortic injury grading was first proposed by Starnes back in 2012, and it's gone through a few revisions, but basically this patient, large intimal flap pseudoaneurysm range. Next slide. And these patients need urgent or emergent endograft if the other injuries don't take precedence. And this is for low-grade injuries, intimal tears, easy. Those can always be watched, and we often do serial scanning on those patients, and particularly in the setting of closed head trauma, we'll defer sometimes for many days treatment of a minor intimal injury. But a pseudoaneurysm stays pretty high on the triage list, and we very quickly are planning these, and we do these in collaboration with vascular surgery here at UVA, and we do these 3D reconstructions, trying to see basically can we preserve the left subclavian artery, what size graft do we need, and what length graft do we need to cover the whole area of injury and not cover any more precious intercostal arteries than necessary. You can see here that the distance from the left subclavian artery to the injury is 13 millimeters. For thoracic endografting, 20 millimeters is the standard, but in trauma we often pinch on that and get away with it. And in fact, in this study in General Vascular Surgery back in 2013, they found in their series of about 60 patients, the mean distance was 15 millimeters from the left subclavian artery to the start of the injury. And that's been our experience here at UVA as well. We consider even a centimeter an adequate proximal seal zone in a young patient where there's no atherosclerosis. That graft can get against the wall and make a seal. The other thing you have to your advantage in endograft for trauma setting is since it's a pseudoaneurysm, it's intrinsically got no outflow. There are no intercostal arteries to keep that aneurysm perfused, so they tend to seal quite readily. Next slide. The other thing we worry about, of course, is cerebral circulation here. If we're going to be covering the left subclavian artery either intentionally or unintentionally, we need to plan for that eventuality, and that means at least at the top slices of your CTA, looking at the size of that left subclavian artery. And what the literature shows is when it's small, two things can happen. Patients get arm claudication. They don't have a large vertebral artery, then they're missing a big collateral pathway to the arm. And in fact, 36% of those patients end up with claudication, and these probably over half the time end up getting a bypass. And the risk of stroke is always there, but at least in this series, and I think most operators would agree, is relatively small. Next. And so looking back now, this is the timeline of this patient. Notice the contact with radiology is multiple phases. First are the chest pelvis film, and then the post-chest film after chest tube placement. And all that's done portably. It doesn't eat into the trauma surgeon's time in evaluating this patient and stabilizing this patient. Then comes the trip to CT, 15 minutes from first slice to the last, which isn't bad, but it is quite a long time. You can see the transport over to get those CT scans also involved probably close to 10 minutes. So radiology is crucial, essential, obviously, but still room for improvement. Finally comes the trip to get the end graft, and this is about an hour's time span, and there's several things that happen in there. Of course, the planning we talked about has to happen. We have to make sure we have the grafts on hand, and obviously one can't be a trauma center without having a complete inventory of appropriate grafts for these patients. We do these in what's called OR 29. You see that listed on the second to last line, and that's a hybrid OR. We did these in interventional radiology for years, which actually worked just fine, but having them in OR 29 does open up the possibility for orthopedic procedures or in other procedures that maybe are slightly down the triage list compared to the thoracic aneurysm repair. Next slide, please. And just a couple images of the process. Here's a 28 millimeter graft being inserted into the aorta. Next slide. You can see the angiogram here through the contralateral placed pigtail, and we're positioning that graft actually proximal subclavian initially because they tend to blow back a bit as you start to open them up. Next slide. Here it is now, the little figure 8 radiopaque markers of the leading edge of the cloth, and that's placed just to the left subclavian artery. And already you can see the pseudoaneurysm is barely filling. And next slide. We finally deploy what we call the top cap, the bare metal component of it that straddles the subclavian artery, and the pseudoaneurysm is already sealed. And often this is all that's really needed. It is sometimes appropriate to balloon dilate the graft a little bit to make sure you get a seal. Next slide. A few words about access in these cases, and this is probably one of the biggest barriers to rapid deployment of one of these endografts. And these patients are invariably in shock, and we get very small measurements in these external iliac arteries. If this patient had had a CT scan before the trauma, we may have seen a very different picture here. But you can see here that we proceeded with placement of the endograft despite the small measurement. It's a bit of leap of faith. The lack of calcium, the relatively straight vessels in this patient make us confident that the vessels will stretch even if this 5 millimeters is a real measurement and not just a hypoperfused measurement. But you can see how the device is totally occluding the left femoral artery here, and the external iliac artery has no flow in it. So these devices definitely stretch these vessels, and this was done through a cut down, which doesn't really buy you any insurance against rupturing that external iliac artery, but perhaps does provide a little bit of quicker access in the event that does happen. Next slide, please. So one of the things that's going to really change our response time, or at least the time to when we actually get that pseudoaneurysm sealed, is the size of these devices. And the manufacturers have been driving the size of these down slowly over the years. And finally, we're starting to see some devices, the Cook Alpha and the Bolton Relay, 16 French outer diameter for the Cook Alpha, 19 French outer diameter for the Bolton, that really you can use in any adult, male or female, with pretty high reliability. So being able to do these percutaneously speeds up the procedure, reduces injury to the lower extremity arteries, etc. Next slide. And here's a post picture in this patient. We got a CT at 1 month, which is a standard for all endografts, and very good result here. Some resolving lung problems you can see, but patient did great. All right, that is a very quick tour of thoracic endograft. Why don't we go to any audience responses?
Great, thank you for that presentation, Dr. Engel. That was awesome. We're nearing the end of our webinar here. If any members of the audience have any questions, we might be able to get to maybe one or two. So just please type your questions into the provided chat box and send directly to my name there. And then while asking questions, just indicate if you'd like to direct the questions towards an individual or the whole group. And while folks are submitting questions, if they have any, I'll open up the floor. If any of the panel members have any final comments or questions for each other, you can go ahead and do that now as well. We'll just go ahead and give it a minute or two here. If you don't get any submitted questions, we'll go ahead and wrap up the webinar. Okay, we have one question here. Okay, and this question is directed towards Dr. Calland.
I'm sorry, I'm not seeing the question. Could you read it back?
Yep, I'll read it back. It looks like it's only been partially sent here, so I'll wait for the asker to maybe finish sending it there. Another question we have here, just for the panel as a whole, with pending acidosis, what are the preferred sedatives and analgesics in trauma?
So I'll start on that one and say that the most important treatment for metabolic acidosis, obviously, is to treat the underlying problem. And in terms of sedatives and analgesics, you know, I think that the thing that I would say is start out very, very small. And frankly, I get an average of 830 looks every time somebody asks for fentanyl, and I tell them to start with 25. And it's just with the acknowledgement that some patholysis can occur with any, you know, sort of substantial large doses of fentanyl. And so I think everybody sort of here has heard 100 times over the course of their career, you can always give more. So we start with low doses of fentanyl, and then the idea is that the most problematic patient here is not so much even the one that's acidemic, and needs sedation, because that patient needs aggressive intervention, intubation, transfusion, probably a central line with access to give vasoactive drips for impending circulatory collapse. But to me, the one that's even more dangerous is the one who's actually already, frankly, hypotensive and acidemic and needs sedation. And that's a patient where I will sometimes actually get a milligram per kilogram of rocuronium available. And sometimes if the patient is thrashing around and either a danger to themselves or to the other team members who are about, I will give a paralytic and then give judicious amounts of a benzodiazepine in order to maintain my own humanity in not having a patient who's chemically paralyzed without a sedative on board. But we're talking about 1 milligram of Versed, a half a milligram Versed, et cetera. And then the idea being that sometimes just getting the patient still for a period of time, we can then sort of undertake the imaging and diagnostic procedures that are needed in order to find out where they're bleeding or what exactly the problem is. Now, I'm sure that there are people present who are saying, hey, what about ketamine? And I think that this is, I'm really glad that this question came up, because ketamine can maintain or augment blood pressure slightly when it's given as a dissociative sedative. But I think that the key thing is that once you start getting above a milligram per kilogram or a milligram and a half per kilogram, you can get sympatholysis from that medication the same way that you can from general anesthetics. And it's not surprising to see circulatory collapse, the same way you would during induction from other agents. So I think that the take-home message is probably less than a half milligram per kilogram of ketamine in association with whatever analgesic you're using can be used as a pain adjunct. If the patient is immediate danger to themselves or staff because they're thrashing around or violent, consider using a paralytic early in those patients, but try and give it with a benzodiazepine. And then if you are going to give analgesic only, start low and go slow.
All right, thank you, Dr. Calland. Any other comments on this question? Okay, and I think we'll have time for one more question here. The final question, I think, also directed towards, this was the question directed specifically towards you, Dr. Calland, and that is, how do you decide triage in these challenging cases that need multiple disciplines?
Oh, I think that's really a fantastic question, and I want to echo several of the other presenters that pointed out this tension that we have about the maxim that many of us heard during our training, which is that the sickest place, the best place for a moribund trauma patient is in the operating room. And obviously, we love this idea about a hybrid suite where we can undertake resuscitation, care by a trauma surgeon, a vascular surgeon, an orthopedic surgeon, and an interventional radiologist all at once. That's obviously desirable. And for people who are sort of thinking about this further upstream, I always joke about this when I'm giving the lecture to the third-year medical students. I say, how many of you have watched a trauma alert? How many of you have seen me standing over the shoulder of the chief resident as they run the alert? What do you think I was whispering in their ear? And I whisper in the microphone at that point. I say, hey, how do you think the airway looks? How do you think the airway looks? Do you think we've adequately addressed the airway? If so, do you think we need to place chest tubes? What do you think of gas exchange? And then for circulation, I say things like, do we have enough access? Where do you think the patient is bleeding? Have we triaged all the body cavities? And so I think that in terms of prioritizing injuries, sometimes the trauma surgeons seem, like how do they manage all this? Just like how do they keep all of this in their heads? These multiple injuries to the aorta, the brain, the spleen, the pelvis all at once. Believe it or not, it starts with A. It goes to managing gas exchange and breathing next. Aggressively treating hemorrhage control and placing access, and then treating neurosurgical emergencies last.
All right, thank you, Dr. Calland. Any other comments on this question? Okay, if not, we'll go ahead and wrap up the webinar here. I want to, again, thank our attending panel so much for taking time out of their schedule to speak with us tonight. Dr. Suri, Dr. Calland, Dr. Conrad, and Dr. Engel, we really appreciate it. I think this was a great discussion, very interesting things for us to think about. And really, again, just really appreciate you volunteering your time for this. I want to thank Leanne for helping co-moderate the webinar, and I want to thank Maggie for helping with logistics and setting this up. And again, if we don't have any other questions or comments, I'll go ahead and wrap up the webinar, and good night, everybody.
Thank you.